This episode is actually really near and dear to my heart because we'll be talking about suicide prevention and assessment. This episode is sponsored by When the Music Stops, a nonprofit and community that supports emotional and mental health through music, connection, and love. You can learn more at whenthemusicstops.org. A disclaimer is this interview is not endorsed by or reflects the view of the Veterans Administration. Welcome to the Color of Success podcast. I'm your host, Dr. Stephanie J. Wong. Today, I have a very special guest, Dr. Tate Guelzow, and he is a clinical psychologist specializing in suicide prevention. He earned his doctorate in clinical psychology from UC Berkeley and completed his pre-doctoral internship and postdoctoral fellowship at the San Francisco VA Medical Center. In his current role, Dr. Guelzow assists in the clinical management of high-risk patients, the education of staff, trainees, and community partners, and implementation of mandated best practices in suicide prevention. His current areas of interest include narrative approaches to suicide risk assessment, critical suicidology, and effective strategies for supporting clinicians who have lost a patient to suicide. I was super impressed by Dr. Guelzow when I went to a training, one of the most engaging trainings I've ever been to. I'm not saying this to blow smoke. I actually invited him after going to the training, so not before. So welcome, Dr. Guelzow, to the show. Thank you so much for joining us.
Yeah, well, thank you for having me. Appreciate it.
You know, the holidays are coming up, and I wanted to kind of shatter some misperceptions about suicide rates, and also what are we facing really as the pandemic has hit us, and what do we know about suicide statistics at this point?
Mm-hmm. Yeah, well, so that's an interesting question. So there's a number of different pieces to it. Over the last roughly 20 years in the US, suicide rates have been climbing pretty steadily. There was a 2019 study conducted by the CDC that found that there was a 35% increase in U.S. suicide rates between 1999 and 2018. And rates are basically, they're at a 50-year high right now. The sort of per capita rate in the general population in the U.S. is about 14.5 suicide deaths per 100,000. In terms of the pandemic, it's actually been really interesting. When the pandemic first broke out, there was a tremendous amount of concern that suicide rates might spike further, which, I mean, to be perfectly honest, were concerns I very much shared, because past sort of broad global catastrophes and challenges, they have seen sort of concurrent increases in suicide rates. For example, the financial crisis in 2008. And one caveat to what I'm about to say is that getting sort of definitive suicide data is challenging and takes a lot of time. So typically, it's about 2 years out. So the most recent year we've got data for right now, for example, is 2019. So everything about the pandemic is still sort of preliminary. But that being said, there have been some studies that have been published that have sort of looked at early markers for suicide rates that have shown that they actually have been lower than is normal since the pandemic broke out. Yeah, which is very counterintuitive. And they've seen that in different countries. It's not just in the US. It's not been seen everywhere. Japan, for example, initially the rates went down and then they sort of rebounded. And a lot of folks in the suicide prevention field, when there wasn't a sharp spike right in the beginning, started to say, well, okay, maybe, but this will be sort of an endurance test. And, we'll start to see some increases, but that hasn't really been the case yet. It still could shift. But, that being said, there have been real significant spikes in things like overdose deaths, car accidents, homicides, other things like that. So it's puzzling, in a good way that the suicide rates have not jumped in response to that yet. Again, it's very preliminary. Around the holidays, it's interesting you mentioned that because that's sort of a widely held misperception about suicide. There's a lot of talk amongst mental health professionals about sort of gearing up to assist our patients during the holidays. And I think that's a great thing to do. The holidays can be really stressful for a lot of folks. But data shows year in and year out, this is pretty consistent. The highest rates of suicide actually occur in the spring. So sort of March to May, and actually December tends to be some of the lowest rates that we see.
What do you attribute to that? I mean, obviously there's no definitive reason, but the misperception is that many people may get depressed, commercialism, all those kinds of things. So why do you think spring is the time, I guess?
It's, and so I'll also pan out a little bit. That brings up another point. So suicide, just so that you're aware, is a woefully underfunded area of research, and it's an incredibly poorly understood phenomenon. So I brought some numbers. This is the 2017 research budget for the National Institutes of Health. And again, suicide is the 10th leading cause of death in the US. And that year, the NIH's budget for cancer, which is the second leading cause of death, was $6 billion. That was their research budget for that. For kidney disease, which is the 9th leading cause of death, it was $592 million. For suicide, which is the 10th leading cause of death, it was $68 million.
Wow.
So it's a just absolutely woefully underfunded and poorly understood phenomenon. And it's also really complex. So I say that to sort of frame the answer that I'm going to give, because it's the answer you often give when you're talking about suicide. It's sort of like a little from column A, a little from column B, could be a lot of things. Around the spring suicide phenomenon, the stuff that I've seen in terms of what people theorize is that it may have something to do with sort of affective states and certain mood disorders, particularly bipolar disorder. A lot of times folks are, this is in some ways a little bit pop psychology, but it is, I've seen it in a lot of respected journals as well. The notion that sort of when folks are in a deeper state of depression, oftentimes sort of the kind of the push to do something as sort of assertive as make a suicide attempt is often kind of out of someone's reach. Whereas, once the sort of seasons start to change, the sun's out longer. First of all, folks with bipolar disorder may be more likely to sort of kick into a mixed state or a manic state. And so they've got more energy while they're still feeling pretty depressed. Also, I was reading about this recently, actually, it's someone from Johns Hopkins, and they were saying, it may be sort of like contrast effects. In the winter, everybody's kind of hunkered down and sort of a little bit more solitary. But then in the spring, everybody, you're seeing everybody else is kind of the world's coming alive, and you still feel really crummy. I also read recently, this is another person writing at Johns Hopkins. They theorized that maybe inflammation might have something to do with it, that allergies have been tied to depression. Yeah, because increase in inflammation can exacerbate depression. So, that's sort of indicative of what you see a lot of times when you theorize about, something as multifactorial as suicide. There's a lot of different theories and doubtless a lot of different contributors.
Absolutely. And, I don't want to overgeneralize, but a lot of our listeners are Asian American, and, they'll message me, they'll DM me on the side and just say, like, I've been through, suicidal periods in my life, or, bipolar, et cetera. Usually Asian Americans have lower rates, but I imagine that there's a lot of underreporting, not only among Asian Americans, but in many, all groups, and minority groups. So, what sorts of risk factors do you see in people that tend to be more prone to ideation or even making an attempt?
Yeah, well, so there's a host of risk factors, and, I always sort of caveat descriptions of risk factors by saying, the way to think about these things is they're good things to just be aware of, as sort of signs that it might be good to like initiate that conversation with that person and ask them, that question, are you having thoughts of suicide? That's one of the best things you can do to support someone, is being willing to sort of take that leap. But so, I offer this caveat because the reality is we all have risk factors, right? Like, I'm going to go through these and you'll hear them, and they're very general, right? And the reality is you may have a room with 150 people who are experiencing risk factor X, and maybe only one or two of them would ever even dream of, considering suicide. So it's that's a good way to think about these, is sort of, these are kind of, they're just warning, like sort of flashing signs about, hey, you might want to have a further conversation with someone. But so that being said,
just real quick, the question of, are you thinking about suicide? So a lot of misperception and the myth that if someone asks, that it implants that thought in their mind. I mean, can you speak a teeny bit on that?
Yeah, absolutely. Yeah. So that's, suicide is really something that's shrouded in a lot of kind of bad conventional wisdom and sort of things that are widely accepted that just aren't borne out by data or, my experience. So I've worked on crisis lines in high school and college, and in my current role for about 7 years. And, the reality of it is I've asked that question a lot of times. And, in the vast majority of times when I ask, are you having thoughts of suicide? Very often the response is, oh gosh, no. Like if things are bad, things are rough. Yeah, I'm struggling, but no, I would never do that, for the following reasons, right? So that's the most common answer. The second most common is sort of a long exhale. And then, yeah, I am, and I think that exhale sort of speaks to the fact that, if you're sort of in the position that you're having a conversation like this with that person, you may be the first person they've ever been able to share that with. Sure. I've never had anyone say, I wasn't, but now that you mention it, maybe that's not such a bad idea. It's just, you're not going to implant the idea in folks' heads. And there have been some studies that have borne that out, where they've looked at, like, does asking about suicide sort of increase the availability of it as a heuristic? And they found that it doesn't. Okay. But I think it's interesting because I think that sort of myth speaks to, in a lot of ways, our discomfort with this topic. Yeah. Right. Like, it's sort of like, I don't want to ask. And I'm afraid if I do, I might sort of upset the balance or whatever. But, the reality of it is, again, I've had this conversation a lot. And, the majority of the times the answer is no, frankly. But then when it's yes, that's an opportunity, it's an extraordinary opportunity to be able to sort of be with somebody during that time.
Yeah. And I'll go back to the risk factors, but I wanted to briefly ask you worked on multiple crisis hotlines. This is your area of specialty. What led you to say, I want to specialize in suicide prevention?
Well, it's actually funny. I always sort of joke, teenage truculence, I think, largely shaped the trajectory of my life because I was kind of an insufferable, 14 or 15-year-old. And my mom she's a psychologist. And I was laying around one summer in Southwest Virginia complaining about how there was nothing to do and my hometown was so lame. And my mom basically finally got fed up and took me by the ear. And she's like, you're going to go volunteer and do something. And she volunteered. She worked with the local crisis center. And they had just started they called it Teen Line. And they had just started that like a year earlier. And I did that and I loved it. And then I did it in college too, in Colorado. And and in terms of professional, it's interesting. I mean, I've had kind of a circuitous path. I worked with kids for a really long time, worked in a kid lab at Berkeley for grad school. And then it was honestly just sort of the job that came up when I wish it was something more sort of, I had a purpose in my life from age 10 or something, but it was kind of the job that came up. And over time, I do think I've gotten, I've got some good skills, I think, around helping people out when they're struggling in that way. But a lot of it is kind of happenstance and sort of teenage ennui.
Well, I never thought that I would love substance abuse treatment. So there you go. I mean, it's weird, things right? Just happen, when you go through training or like life experiences. So
it's funny.
Yeah. So going back to those risk factors, I know you said that they're pretty general, but
sure.
Just so that people are kind of aware of these general factors, it would be helpful.
Yeah. So some of the things to look for just in terms of what a person, may look like when they're in a suicidal crisis. Anybody reporting hopelessness or sense that there's no way out of their situation, anxiety, agitation, sleeplessness or mood swings, feeling like there's no reason to live, rage or anger, engaging in risky activities without thinking. Also, any exacerbations in mental health symptoms or also medical problems. So around medical problems, particularly new diagnoses, or significant progressions in a disease process. So if someone has a chronic disease, but say, they've just crossed a threshold and now they're not able to, walk, say, or something like that, they lose a big sort of element of their functioning. That can be really devastating. Increasing alcohol or drug abuse, withdrawal from family or friends, psychosocial stressors. And it's important to keep in mind when you think about psychosocial stressors, the ones that seem to really, be most implicated are ones that involve sort of a fundamental change in status, kind of a fundamental change in how the person sees themselves. So, loss of a really serious relationship, right? Loss of housing, things like that. Loss of a job, something where it's kind of like the person's very sort of core concept of who they are gets really, kind of rocked or sort of shaken. And then also the biggest risk factor, the most significant risk factor is a history of suicide attempts. That's the biggest predictor of future suicide attempts. And then also a family history of suicide attempts. But again, I really caveat that with just these are warning signs. These are things when you're seeing them that it's good to think about, okay, maybe I should be having a little bit of a deeper conversation with this. I also really encourage people, think about departures from baseline, right? So it's not the case that some people just run a little bit angry, right? Some people have lifelong difficulties with sleep, right? That doesn't necessarily mean they're at elevated risk for suicide, right? Are you saying, is it a real shift for this person? Is there something real different about how they're presenting? Are they not sort of themselves? They seem, they're going through something and they're presenting, they don't seem like themselves. That's particularly concerning. There's sort of a really gross distinction that's made between risk factors and warning signs, and there's not a lot of data. It's one of the holy grails of suicide prevention is to try to find, a risk factor or a warning sign that, like, if the person presents with this, then that's the person that's at elevated risk for suicide. They don't really exist because they tend to be too general. They tend to be things that you see all the time in a psychiatric emergency department. So that being said, things that are real warning signs, and these are pretty obvious, but things that if you hear this from someone, it's a sign, you probably need to be trying to get them connected with some help as quickly as you can. So any disclosure that they're thinking about hurting or killing themselves, obviously, if you become aware that someone's looking for ways to die, taking steps towards suicide, like anything where it seems like the person is going from thinking to action. So, you often hear about people giving away possessions, getting their affairs in order, things like that. Also, any increase in self-destructive or risk-taking behavior, particularly if there's alcohol or weapons involved, and any efforts to acquire lethal means. So that's sort of, people looking to buy guns, right? People stockpiling medications in anticipation of an overdose, that sort of thing. Those are sort of more like flashing red light. Like if you encounter that, that's definitely cause for significant concern.
So I think one of the common questions I get is, okay, I have a friend, family member, whatever, that is kind of experiencing these things. Like, I notice a change in behavior. What can people do when they see that? Like, because like you said, people can get nervous to talk about this issue, even though they observe some changes in behavior, or even people telling them this information.
Sure. Yeah. I mean, honestly, like I think one of the biggest pieces of this, and it sounds so simple, but it's really not, and I say, like, I've had a million of these conversations and I tend to run kind of anxious, just sort of how I'm wired. I still, when I ask the question, when I'm on the phone with somebody and I've got, my sort of, my antenna are starting to vibrate, I'm nervous, it's an anxiety provoking topic. It just is, right? And it's not something that we talk about a lot as a society. But so all that being said, I think one of the best things you can do is just really being able and willing to ask that question. Are you having thoughts of suicide? And I really encourage people, think about how you might ask that. There's no perfect way to ask it. I do often encourage folks, like, don't punt on saying suicide. Like, a lot of times people be like, are you thinking of hurting yourself? And things, they get sort of mushier.
Yeah.
I often just, it's uncomfortable, but just sort of have out with it, So, I mean, I think that's one of the biggest things is just sort of identifying yourself as someone that, like, I can handle this. Like, I can take hearing this. I'm willing to ask this question because I care about you. I think once if the answer is yes, a lot of it is just about how you receive the information, and so one of the best things, and I remind myself, I mean, I'm a talker and, like I said, I run anxious. And so I can just talk and talk and talk and talk and talk. And sometimes I'll be on the crisis line and I'll just be like, dude, like, shut the F up. Like, you're talking, like, listen more than you talk, basically. Like, I'll realize, like, you have said 10,000 things for the two things, like pump the brakes. Right. And so that's one of the best things I tell, like, if you find yourself in one of these conversations, listen. Right? Like, just listen. That's one of the best things you can do. And it makes it easier for you, right? Because you can kind of exhale and collect yourself and sort of get back on your feet. So yeah, a lot of times it's just sort of like, let the conversation breathe, right? Like, listen more than you talk. Also really resist the urge, people have a million different thoughts and a million different judgments about suicide that come from a million different places, right? Like, might be your religious beliefs. It might be your own personal experiences or losses that you've been through. You want to really try to do your best to sort of check the judgment as best you can. And I think another thing that folks can do, and it's very well intentioned, but a lot of times there can be a rush, and I feel this myself, and I'm a professional and I've been doing this for years, to sort of take it away from them, to kind of be like, you're in pain, you're in distress. It's kind of stresses me out, frankly. So I'm going to be, we'll just get you some help. It's all going to be okay. You're going to be out, sort of just kind of brush it aside a little bit. Yeah. And I think it's a very human, and it comes from a good place, right? Like, we're trying to offer reassurance. But I think oftentimes for the person that's struggling, that can feel, because very often they're where they're at because they've not felt validated in their struggles. And so to sort of reach out to someone and take that difficult step and then sort of have, kind of get patted on the head a little bit, can be sort of further invalidation.
Well, the other thing too is not jumping in there and being like, you're not thinking about suicide, are you? And then, it's just kind of more accusatory or just kind of heightening that anxiety.
And that's a beautiful point. That's a very delicate and perfect. Yeah. I appreciate you bringing that up, because that's one of the big, don't ask it in the negative, right? Because it's very easy to ask that question so that it's clear that you are praying the answer is no. Right. And if you do that, the person will take you up on it. You're like, you're not thinking of suicide, are you? Like, you have identified yourself as someone that is not interested in hearing about that. So just really trying to kind of, just make that space. Beyond that, I think that, encouraging folks to get connected and stay connected with supports, I'm a psychologist, so I tend to go towards mental health, that mental health treatment is very helpful. And of course it is helpful for a lot of people. It is not at all the only show in town, right? For some people, support may look more like, a spiritual community, re-engaging with a social group that, they've sort of drifted away from, things like that. But I think in terms of, if you're a friend of someone that's struggling in this way, sort of trying to both you stay connected with them and then encourage them to get further connected. Because I think oftentimes what undergirds suicidal crises is just, there's a sense of sort of broadly that what I am facing outstrips my resource. I'm not equipped to deal with this. And oftentimes, not always, but very often, it's the case that the person feels horribly isolated and alone in that struggle, right? There's a theory of suicide that's very in vogue right now. And they talk about three different facets that are very common in suicidal crises. One is called thwarted belongingness, which is sort of, again, this sense of just like profound alienation and isolation from others. Another is perceived burdensomeness, and I hear that very often. People get into this sort of this spiral of, I've got this family, and you know what, I'm a burden to them. They're going to be so much better off without me. And it's so I think helping people and encouraging people and getting connected. Then I think, if you're dealing with someone that is in a suicidal crisis, I think just it's good to stay close, as best you can, and kind of have other people kind of, like sort of have the web of support kind of be there for the person, as they're struggling. I've known cases where, people's friends will kind of, they'll sort of put their heads together and be like, okay, Saturday, can you hang out? And they'll say, we're going to kind of be with you, walking beside you right now while you're struggling, because we want to make sure we help you get to the other side. So things like that can be really helpful.
Well, I think the other thing I wanted to ask too is like, how can friends and family also set up boundaries? Because often there are people that go through these cycles and these waves of suicidal ideation or even attempts. And sometimes even because that's the strategy that seems functional to them at that point to deal with pain, it can really tire people out, so to speak, and exhaust them. So what can people do as well to make sure that they are taking care of themselves while at the same time being present with the support?
Yeah. So, I think about, because that's an excellent point, when especially if you're in a family or you have a loved one who struggles with, significant sort of long-term mental illness, oftentimes, it can just be sort of a roller coaster of, good periods and then periods that are more difficult. And I think that, it's as with anything, like we can only be as helpful as we are, I've dealt with this in my own life, and my own family, just sort of, if you're not taking care of yourself, you're not able to be a very effective advocate or support for anyone. I think things like, NAMI, they have a lot of family support services for, family members, folks that are struggling with mental illness. And then also just basic self-care. Like I hate that that's often the answer, but also in my own lived experience, it's very true. When I've dealt with family members who are going through different sort of mental health struggles, there've been periods where, I have not been eating or sleeping very well. And I have behaved I've not been my best self, and I think when I'm able to be like, okay, you know what, I need to eat a decent meal and I need to get to bed at 9 and, so that I can continue to face this.
Yeah. That's the balance, right? Is that it is a stressful situation and you truly care about a person, and it can be very taxing to continue to be in that role.
Absolutely.
But you're absolutely right. That self-care, and it's become somewhat of a buzzword lately. And at the same time, we have to really think about our mental health and the emotional labor that's kind of put into, all of that, and helping other people. So what I really liked about your approach as you were describing it, though, is coming from a place of curiosity, because you worked in the ER, you worked in, on the crisis lines. When people present to these, to the ER, for instance, if we can give a sneak peek, how does it look when you're talking with someone that's acutely suicidal?
Well, so, there's kind of the approach that I take, and then there's sort of what ERs typically look like. And I'm happy to sort of speak to both.
Oh, yeah.
So in an emergency room, if someone is coming in because they're in an acute suicidal crisis, they're having thoughts of suicide, they're not sure that they're able to maintain their safety. Typically what happens is they'll meet with a provider, usually some mental health, it could be a social worker, psychologist, psychiatrist. And, they'll basically just sit down with them and just do a risk assessment, which essentially is just, basically a way you're essentially telling your story of where you're at and kind of what brought you here. They'll ask questions to sort of get a sense of, what are your risk factors? What are your protective factors? What are the stressors that you're dealing with right now? And the reason for doing that, there are a number of different reasons. One is, if someone is at imminent risk, if there's real concern that they cannot maintain their safety, then, they may need to be hospitalized for a short period of time while they get stabilized. But another piece of it, and honestly, this is much more often the disposition, is the person, you're asking these questions to also get a sense of where can we help intervene with this person? What are the areas of difficulty? Maybe a consult to a social work service, what are the different resources that might be sort of what are the drivers of this crisis? And so that's another piece of what folks do in emergency rooms. Also, increasingly, there's, and this is sort of a burgeoning area of interest in the field. It's I don't know if it started necessarily in the VA, but it definitely is very sort of heavily entrenched in the VA now, is something called safety planning. So it used to be the case that, and I remember this from when I was getting trained in college, back in the 90s, they call it contracting for safety. So, it was like when you talk to somebody on the crisis line at the end, you sort of, you talk to them for a while, you get some rapport, you make a connection. And at the end of it, you say, hey, listen, I'm glad you're feeling better now. Could we kind of make an agreement, and that agreement is, if you're ever having thoughts of suicide, you're gonna reach out again, right? And that was sort of just the coin of the realm. That's what everybody did, and you still see it sometimes in charts. I review charts a lot in my job, and you often see, contracted for safety. The difficulty with contracting for safety is, first of all, it's not legally protective. A lot of providers think that, like, oh, I'm covered. I said I contracted for safety. It's not true. And the difficulty with contracting for safety is it basically asks the person to make you a promise, but it doesn't really give them any tools to deliver on that promise. You're just basically saying, like, yeah, sure, doc, I'll give you a yell if I'm suicidal again. So a safety plan is, basically the provider sits down with the person, and it's a 6-step plan. And basically you both write it out next to each other. It's a very collaborative process. And you just identify, you start out, what are the warning signs? Like, what are the things that show you, it might be time to break out the safety plan, so when you're in a crisis, typically in the days leading up to it, what are the things that you see? Then it goes to sort of, what are the coping skills that you can use on your own? And you sort of sit down with them and you really chew over each of these things. And then it goes to, who are people you could reach out to in a crisis that are friends, then who are the professional helpers? And then also, what can we do to keep make your environment more safe while you're going through this crisis or in future crises? And so that's really caught on of late, particularly in the VA. It's ubiquitous in the VA now, but it's outside of the VA as well, in emergency departments around the country. And so that's another thing that folks may encounter. If it's seeming like, what, we've done our assessment, it seems like, you're okay to go home. We're gonna, we gave you some numbers for different resources you can call. Let's do a safety plan too. That's often how that can go. But yeah, in terms of, how I tend to try to approach when I'm dealing with folks who are sort of at that point, who are having thoughts of suicide, I really try very hard to sort of proceed in a way that is just like, again, just maximally curious and, just as open as I can possibly be. We as providers often get really grabby around suicide. We get really sort of paternalistic, and frankly, we get anxious. And so that can manifest in a lot of ways that, can feel really overwhelming, and also it can create sort of like tug of war dynamics with patients, and, I had one experience once where I was working with a patient who had traveled thousands of miles to jump off the Golden Gate Bridge. And when I sat down to speak with them and told them, why I was there, they told me, they said, I'll speak to you, but just so you're aware, I'm going to die by suicide someday, and there's nothing you can do to stop me. And I just said, here's the reality of it is, at the end of the day, you're right. Like, I can't follow you around 24 hours a day. I can't, wrap you up in bubble wrap. And I don't think either of us would want to live that way if I could. But, I was like, but the reality of it is I've talked to a lot of people who are going through similar things. And in my experience, one of the issues with suicide is, it is a choice, right? Like, you have that choice, and that's just a fact. Like, everyone has that choice. But what I said in that case, and I've said this to a lot of folks, is, just the reality of it is a lot of times people make that choice with really garbage data, right? Like, they make it when they're deeply depressed. They make it after they've just had their heart ripped out, a terrible breakup. They make it when they're using again, things like that. And they just, and I'm like, this is the most important decision a person can make. It's live or die. This is it. So, if it's cool with you, like, I'd love to, like, let's just sit down and like dump the puzzle pieces on the table and kind of do the puzzle together and just see what we come up with. And in communicating that, like, I've communicated a few things. Like, I haven't been like, oh, no, that's not acceptable that you say you're going to die by
suicide. You better
I
not jump off that bridge.
Yeah. I mean, at the end of the day, I'm saying, like I and I of course say, I hope like hell that doesn't happen.
Yeah,
right?
Exactly.
But kind of not engaging in the struggle, because I think that's another thing is a lot of times, particularly folks who are chronically marginalized, who are struggling in this way. You're dealing with folks who it's like they've had a lot of autonomy taken from them. Right. And so to be sort of as a clinician coming in sort of like, I'm going to take this other thing from you, you're not going to get very far. Right. I've found time and again, like that approach when you're willing to just say, hey, can we just like, let's chew this over. Right. Like, let's get curious. I'll talk sometimes too about, there's this one quote from this guy. Let me see, I booted it up earlier. This is a guy who survived a jump off the Golden Gate Bridge. But he essentially said, I can still see my hand coming off that railing. And I realized in that moment that everything I thought wasn't fixable was completely fixable, except for having just jumped. And I'll share that with folks too. I'll say, that's the thing. It's like, this is the most important decision you can make. So, if it's me, like the worst thing I can imagine is making that decision and, in the last few moments of life, realizing like, oh my God, there were 20 different things I could have done that I didn't do. So I think a lot of times just like having a conversation and I think continuing to sort of keep a focus on the person's humanity, right? Because there's some interesting stuff in the nursing literature about, there's one article that talks about how when people disclose suicidality, they often are instantly reduced to what the author referred to as risk objects, to be sort of assessed and analyzed and it's sort of like they lose some of their humanity. And I see it, I see it all the time. And I think that we as healthcare, like, as I'm talking, we writ large as American healthcare, really do that a lot, and I think it's not very effective. And we get into stupid power struggles that, because at the end of the day, that guy was right that said that to me. There's a lot we can do. Right. But at the end of the day, we can't do absolutely everything. Yeah,
absolutely. And, I think I'm so glad that we're talking about it because you mentioned like Japan's rates are high and, Korea's suicide rates are really high. And when many people go to therapy, they use fake names. There's a whole bunch of stigma involved. And so just even talking about this and having a safe space for clients to go to, for people to present to the ER and just have a conversation. And I tell people that's pretty much what therapy is. Of course, we go through extensive training. We have theoretical models and we can spout a whole bunch of, jargon. But at the end of the day, it's like what people are really looking for is someone that can validate them and help them problem solve if they want to.
You can just sit with them and be with them, and just be like, I can take this. I'm here and I can take this, and again, therapy, of course, I'm a psychologist. That's where I go in my mind. But like, for other people, that could be a chaplain, right? It could be a treasured friend. I mean, I think it's so much, it's connection, and it's interesting because people, when I think about the rising rates of suicide, I think something that we've also done in America, I mean, as with a lot of mental health stuff, we've tried to medicalize suicide. Right. And, I think a problem with that is it sort of puts the onus entirely on the individual. For a long time, they would say things like, 94% of people who die by suicide have a mental health disorder, right? And so it's just sort of like suicide is a problem of broken individuals, so to speak. And, I think that's incredibly, it's incredibly stigmatized. There's a lot of problems with it, but I also think it's sort of sacrificing sophistication for measurability very often. Yeah, it's grossly reductionist. And I think that, a lot of this stuff is I think reflective of a very, a sick society. And, and I think a lot of that has to do with, it's a million different things, I'm sure, but it's sort of just our increased kind of atomization, our lack of connection, our sort of the burgeoning, we all have 8 million quote unquote connections, but they're not actual connections anymore. And sort of, just the shattering of community, and so when I think about just sort of the biggest thing that is connecting, that's not a panacea, and it's also tremendously difficult for some people. So I want to acknowledge that too. Absolutely. It's not like, oh, just go make some friends. Like it's very complicated, but I think that is one of the, if there's sort of a central protective factor of that sort of, the umbrella over all the others, it's connection, and
meaningful relationships.
Yeah, absolutely. Absolutely. Just feeling seen, people that make you feel seen.
Exactly. So where can people go for resources? And I know that it's very cliche, but what's the number? Where can people actually go to, find support?
Yeah. So there are a number of different places. So sort of the big national clearinghouse is the National Suicide Prevention Lifeline. And that is 1-800-273-8255. That number again is 1-800. I have to say this in my voicemail.
I know.
1-800-273-8255. And that's the big kind of it's sort of the big fish nationally. And it's a wonderful resource 24/7, 365 days a year. If you Google it, there's IM and chat, and there's also text available. And that is a wonderful starting place because they also, it's not just a crisis line, it is that, but it's also a clearinghouse for resources. So they have lots of different, if you want something in your area, that can be really helpful. There's also there's a lot more that's local, and so I would always recommend to people, Google, I'm in the Bay Area, so, San Francisco mental health access, like things like that. And oftentimes there are low cost or reduced cost, or sometimes no fee services that might be available if you don't have insurance. There's a lot of other sort of more niche services. So one is the Trevor Project. That's a wonderful, wonderful, wonderful resource for LGBTQ folks who have higher rates of suicidal ideation and appear to have higher rates of suicide. So I really, really encourage folks to check that out. It's fantastic. And then another thing to know about the National Suicide Prevention Lifeline, it is also the Veterans Crisis Line if you press 1 for veteran at the end of that. Because that's another, veterans have a rate of suicide that in 2019 was about 52% higher than the general population. And that's been the case for about the last roughly 15, 16 years.
And, I think the other part, not only meaningful relationships, having these resources, but really addressing, like you said, some of these psychosocial stressors. I have a hard time believing that if you're going hungry, you can't, pay your rent and, all these kinds of things, that you wouldn't feel stressed out. And so I think it, like you said, it's very, very complicated, and it's not reductionistic. So there's resources for those aspects as well.
Yeah, absolutely. Yes. And that's one of, I think the most valuable things we can do as providers too, is really try to get a sense of what are the drivers? Like that's a kind of a buzzword right now in suicide prevention. Like what are the drivers of this crisis? And there's one author named David Jobs who's kind of eminent in this area. And he talks about, he calls it the magic wand question. He says he'll ask people he works with, if we had a magic wand and could change one or two things that would make everything better or go away, what would that be? And he says very often people say, sometimes it's things that can't be changed, like, oh, I would bring back my partner or whatever.
Right.
But very often it's something that is actually quite workable, and that there are resources to assist with. So, just asking those questions, like what, because sometimes, maybe this plane is the nose on your face, just, you're not noticing it until you ask.
Was there anything else that you'd like to convey, or anything I didn't ask that you feel like it's important to put out there?
Yeah, well, I think it's interesting because I'm just thinking in terms of, common misperceptions of suicide, because I think a lot of them, they're really pernicious, and, why they're problematic is that they can often keep people from reaching out for help when they might otherwise. So, one of the big ones is, essentially, if somebody's going to kill themselves, there's nothing you can do about it, right? Like, and if you put up for example, if you put up a barrier on the Golden Gate Bridge, people just jump off the Bay Bridge, right? Like that's a very common idea that you often see. And the reality of it is, they've done a number of meta-analyses, which are big studies where they'll look, they'll amalgamate the results of, up to 100 studies sometimes. And what they have found is 90% of the time, folks that survive one suicide attempt do not go on to die by suicide. So 9 times out of 10, if a person survives a suicide attempt, they will go on to live out a life and die by causes other than suicide. So I think that flies in the face in a lot of ways of a lot of kind of commonly held misconceptions. I think another one that's very interesting is this sort of buys into that, or sort of touches on that notion of nothing you can do to stop them. There have been a number of studies where they've shown that when there are highly available, highly lethal means for suicide, steps to sort of limit access to that can have tremendous impacts on suicide rates. So one example that I just find fascinating. So in Sri Lanka, between the 50s and the 90s, there was a tremendous increase in the rate of suicide until by 1995, it was 47 per 100,000. So in the US right now, again, we're at a 50-year high and we're at 14.5 per 100,000. So 47 is quite high. And 2/3 of those came via pesticide ingestion, which is quite common in agrarian countries. Guyana also has a year in, year out, a pretty high suicide rate, and a lot of it is by pesticide ingestion. It's very common. And so in 1995, the Sri Lankan government decided to ban a number of the most human toxic types of pesticides. And in the 10 years that followed, the national suicide rate dropped 50%.
Wow.
Which is absolutely mind-boggling. I mean, in suicide prevention, if you can move the needle a percentage point or two, you are just ecstatic. So, and a really interesting sub-point of that, though, is that the behavior didn't change. The number of attempts via pesticide ingestion stayed the same. They were just less likely to be fatal because they'd taken out the most toxic ones. And there have been a number of other studies like that. In the UK, in the late 60s, they changed the primary source of home heating from coal gas, which is got carbon monoxide and is quite toxic, to another type of natural gas. And they actually did it for just economic reasons. It wasn't a suicide prevention thing. And in the years that followed, the overall suicide rate dropped by about 1/3. So, that sort of maps on in terms of and this is another piece of what folks can do when they've got someone that they're worried about, is think about, okay, so somebody's going through a crisis right now. What can we do it's called lethal means safety in the field. Like, what can we do to increase their safety while they're going through this crisis, right? So firearms are a big one, right? Like 50% of US firearm deaths or 50% of US suicide deaths are via firearm. So, oftentimes the providers increasingly in emergency rooms, they'll have conversations with patients around like, listen, I hear you're having thoughts about not being really sure if you want to be here anymore. Would you consider, while you're navigating this crisis, what if we had your uncle hold on to your firearms, or you might say your wife hold on to your pills if you're thinking about if you're thinking about overdose or things of that nature. Sort of temporary steps that can be taken while someone is in a crisis to reduce their easy access to lethal means can really, really help. So that's another thing I like to always sort of pitch, because I think that's a very sort of practical solution that a lot of folks can do in their own homes. I have these conversations all the time with spouses and friends of people. Say, hey, look, put the knife in a lockbox, put the knives in a lockbox for a while. Yeah. We give out the VA gives out gun locks all the time. For this exact purpose. And the idea being, again, it's a temporary, we talk about a temporary strategy for storage that's responsive to fluctuations in risk, right? So we're not saying get all guns out of your home forever, flush all your pills down the toilet, right? It's just when you're in a crisis, having like a plan B. It's sort of like drinking and driving. It's kind of a similar idea. Like, when you've had a few beers, that's the time to hand your keys to your friend. And it's the same with lethal means. Right. So yeah. I just plug that.
Well, I know it's a great point, because it's really about also creating a buffer, because it's acute, right? Like you're not, the rationalization is overridden by the emotions and just feeling like there's no way out. And so just if we can create some time for that, the thinking and the discussion and the validation to be available, that's really one of the best things we can do.
Yeah, I talk about decision points a lot. I'll be like, look, we want to put as many decision points between impulse and action. If you're having that thought, like, you know what, I'm done, I can't do this anymore. And then we want to have lots of decisions. So, we've had folks where there was one gentleman who took his gun apart and put the parts in lots of different places. Yeah. And, so basically there was another person who, had to put a gun lock on their gun and froze the key to the gun lock in a block of ice and made a deal that they would basically they needed to do coping strategies while they waited for the block of ice to melt. And, and this stuff anecdotally, I mean, this is a new area of intervention. So, the data is limited at this point, but I mean, I can say anecdotally, I know of a number of cases like that. I mean, ones where, police officers have shown up and somebody's trying to break the gun lock off with a rock,
I mean, there's creativity involved though, right?
Yeah.
And I mean, I'm not comparing like emotionally eating and eating chips to suicide. Of course, it's apples and oranges, but it's just that whole idea. Like you see these things on pop culture TV of like, getting rid of all the snacks and if you have snacks, putting it in areas where you actually have a key and stuff like that.
Yep.
So it's just that idea of like creating barriers to kind of doing something that you may regret later.
Yeah. And just even, even as something as simple, because oftentimes we're working with someone, say with severe PTSD, saying, getting the gun outside of my house, that dog won't hunt. Like that's too big of an ask. Yeah. So, just saying like, listen, what about just taking the clip out and putting the clip next to the gun? Like that's it. Like, and you can, this is when I worked for VA. It's like, you can load that real quick. But again, that's a decision point. Right. Mm-hmm. And then you can sort of work with, okay, so if you ever find yourself at that decision point, what are we going to think about? What sort of skills are we going to try to, it's something again to kind of pump the brakes.
Right.
And I've seen that. I mean, I had a guy who came in once who had just taken 90 minutes walking around his house with a shotgun looking for shotgun shells, couldn't find them and came in instead, and I asked them, said, if you found those shells, would we be talking? And he said, absolutely not. And I said, how certain are you of that? He said 100%, and I tend to believe that, and I think that just speaks to, again, I mean, that wasn't lethal means safety. That just, he couldn't find the shells.
Yeah. It was like luck.
But it was life-saving. Yeah. He couldn't, and I think, and so I think if it's interesting too, because, in the veteran community, there's a really neat website I would recommend if it's called Project Overwatch, I think .org or .org or .com. And it's a lot of young combat vets talking about their experiences with lethal means safety. And I had the privilege of listening to a presentation by a gentleman. He's a peer support specialist at the Mountain Home VA in Tennessee. And he's wonderful. He's just a solid guy. He's a combat medic in Afghanistan. And, he's an open carry guy. And he talks about in his presentation, his firearms have been a part of his family for generations, in the Appalachian Mountains. But he also has some combat anniversaries and anniversaries of other losses that are really hard for him. And he knows. And so he talks about how, and if you look at Project Overwatch, they interview him and a couple of his buddies. And he talks about, when those times of year are approaching, my friends and family know, like they know we've got a plan. We put the plan into action. And every year I, when I'm going through that time, and then we have sort of a routine that we do for when I get them back. And, and it's not about like taking his guns and melting them down into a peace sculpture or something. It's about just having sort of an alternate plan B, in difficult times. So that's a really neat, I think that's a really neat, and again, just kind of practical thing that folks can do. Both, that goes for mental health providers, but also just friends and family. It's one of the best things you can do.
Well, thank you so much for providing your expertise and even just coming on the show, because I know we're trying to, tweak out schedules and things like that. Sure. But I'm so glad and grateful that I was able to sit down with you one-on-one and have a conversation.
Yeah, I appreciate it. Thank you so much, Stephanie.
Thank you. Thank you so much for listening to the Color of Success podcast. Listen, like, subscribe on all major streaming platforms, YouTube, IG, and if you want exclusive content, you can join our Patreon. All links can be found at colorofsuccesspodcast.com.